Hey everyone, welcome back to Dietitians and Nutrition Support. If you've been watching our channel lately, you know that we've been doing an electrolyte series, and today is no different. We're continuing on this series talking about phosphorus management. But first, a few things to know about phosphorus from a general perspective before we get into clinical management. It is super ubiquitous. We have a bunch of phosphorus in the body. We need to know that first off, phosphorus is an intracellular anion. This means that it's mostly going to be stored inside cells, and it's also going to carry a negative charge. If we're thinking about where phosphorus might be, we know it's going to be in cells, intracellular, and it's actually going to be a really important component of both bone and other cell membrane composition. So if we think about cells, you have probably talked about it in biology, the phospholipid bilayer. So phospholipids contain a phosphorus, and phospholipids help make up the outside cell membrane of both those bone and other cells. So without the phosphorus availability, we would not have adequate phospholipids, and thus we may have some lacking integrity in our membranes. So super important just for cell membranes in general to be able to have enough phosphorus. Phosphorus, it also makes a lot of sense, is going to play a role in phosphorylation. So if you're adding a phosphorus onto some other type of chemical compound, which happens regularly in the body, we think about this a lot in terms of energy compounds. If you've ever heard of adenosine triphosphate or ATP, ATP is our primary energy source in the body. That's what our body's going to be generating all the time. It's going to generate ATP, it's going to break off the phosphate bonds to try and release that energy, and this is a consistent cycle. So being able to have adequate amounts of phosphorus that are available to be bound to create ATP, and then you'll see them released as well subsequently when the ATP will break off the phosphate bonds to release that energy. So that whole process of being able to phosphorylate energy compounds is going to be one of our big drives for needing adequate phosphorus in the system. Keep in mind when we're thinking about the phosphorus levels that you're going to get, that lab value is typically coming from a blood draw because this is an intracellular anion. Intracellular, inside the cell, it's going to be a little bit difficult for us to get a really exact measurement of the quantity in the whole body of phosphorus just because we're really drawing from a serum value, and maybe only about 1% of our phosphorus is going to be readily available in extracellular fluid. So it's just a rough estimation of status, although we can still use it to help identify issues within our patients as well. Keep in mind also that serum levels are going to be dependent on a few different things. First, they're going to be dependent on intake and intestinal absorption to get some phosphorus into the body, and then we can think about the excretion of it. Renal excretion is going to be how we're going to either hold onto or lose phosphorus in the kidneys. So if you see any levels of renal insufficiency, you can certainly have some risk for phosphorus concerns as well. And then if we think about bones, bones have this mineral structure called hydroxyapatite that does include phosphorus. So if you're looking at the hormone regulation of bone metabolism, kind of the way that they'll break down and then rebuild bone structures with bone remodeling, if you see any irregularities there, you may kind of see either excess release of phosphorus or inadequate release of phosphorus. So anything that's kind of going on with bone metabolism can certainly impact your phosphorus levels as well. So that's kind of the general perspective of phosphorus, but let's hop over to the other screen and talk about what an individual patient with hypo or hyperphosphatemia might experience and how we can help them to manage that.
So let's start off with our normal phosphorus range. Of course, the values that are accepted for your institution may be a little bit different, but typically you'll see something between the 2.5 to 4.5 milligrams per deciliter as an acceptable range. Note that a normal phosphorus range may be slightly higher for pediatric patients as they're still developing bones. On the left side of the screen, we have hypophosphatemia. So this is individuals who present with levels below 2.4 milligrams per deciliter. Individuals with hypophosphatemia can sometimes present with ataxia, often confusion, weakness, and sometimes cardiac or respiratory failure. In some severe cases, you can also see hypophosphatemia being fatal. I think a common time when we see hypophosphatemia is during refeeding syndrome. This is likely because we are seeing patients that have the macronutrients are just starting to come into the system, and the body needs to utilize a whole bunch of substrates to be able to metabolize all of those macronutrients, and those will typically draw directly from the serum, which can lead to decreased phosphorus levels in those instances. If we think about this in terms of ATP, there's probably a lot of ATP production happening prior or following feeding in refeeding syndrome. So these bodies are starting to utilize all these nutrients to make energy, and of course you need phosphorus to be able to make ATPs, so that will certainly deplete your serum values. This is kind of a similar instance. You'll also see something like that happening with DKA. For individuals who have diabetic ketoacidosis, if they have very high blood glucose levels, their cells are not typically utilizing much or any of that glucose because they're unable to get enough insulin into the system to access that into their cells. So when you see treatment for DKA, which typically includes insulin, as well as glucose in some instances, you'll see the glucose utilization start to ramp up, which again, we're starting to create energy, we're starting to create ATP, and that's also going to draw on those phosphorus serum values. Other times we can see hypophosphatemia are in individuals who have alcoholism. May also see this in times of alkalosis. Similarly, you can see this if you have renal replacement therapies that are a little too extreme potentially, are kind of drawing off too much phosphorus. You can see this in people who have excess intake of phos binders. So these could also be individuals who have some kind of renal insufficiency that's leading them to be taking phosphorus binders. You can see this in individuals with malabsorption, and then finally with people who have low intake. Treatment and management for hypophosphatemia is going to be getting more phosphorus into the system. We can do that orally, enterally, or parenterally. So for orally or enterally provided phosphorus, we're going to see anywhere between 1,000 milligrams upwards to 3,000 milligrams provided per day to individuals. This is typically given also in divided doses. So as you can probably guess, people with less severe hypophosphatemia are going to be closer to that 1,000 milligrams or 1 gram marker, and then people with a more severe hypophosphatemia are going to get up closer to that 3 grams or 3,000 milligrams throughout the day. And with parenteral, you might see anywhere from 0.08 to 0.64 millimoles per kilogram. Again, this is going to be for more of your mild to moderate individual with hypophosphatemia, and this is going to be up into your more severe individuals. Now, if you're going to provide parenterally, you're likely to reassess in 2 hours post-infusion.
So keep in mind that beyond providing additional phosphorus to the system, we also want to make sure that we're taking care of any etiologies that are controllable. So in particular, something like excess phos binders, if we have the ability to reduce down the intake of phos binders to make it more appropriate, or to adjust renal replacement therapies to again make them more appropriate and manage phosphorus in a safer way for our patient, we certainly want to do that.
Now, if we look at the other side of the screen, we're thinking about hyperphosphatemia. So that's that excess phosphorus, very high levels of phosphorus in the serum. This is going to be individuals who are experiencing greater than 4.5 milligrams per deciliter. Individuals with hyperphosphatemia are more likely to present with things such as anorexia, oftentimes with nausea or vomiting. Sometimes they'll experience neuromuscular cramps. Along these lines, you may see individuals that start to experience tingling and general discomfort of their muscles. And then a larger concern for hypophosphatemia is the potential for calcification of soft tissues. This is primarily a concern for individuals with end-stage renal disease, individuals who typically have secondary hyperparathyroidism. So these individuals are more at risk for things such as calcification of the vascular system and of other soft tissues, typically from both hyperphosphatemia, sometimes some excess calcium, and also this kind of stacking of end-stage renal disease and secondary hyperparathyroidism. So if we're looking at etiologies, it certainly makes sense that we'll see individuals who have renal insufficiencies, having concerns in terms of having excess phosphorus levels, likely due to impaired excretion overall. We'll also see individuals having excess phosphorus levels in times of cellular necrosis or any type of cell lysing. If you start to see cells splitting, phosphorus is typically an intracellular electrolyte, right? So if we see breaking of the cells, that release of the phosphorus from the inside of the cells can kind of hypersaturate or increase the serum values. So a few times in which this might take place could be instances of tumor lysis or potentially hypercatabolic states. So our last primary etiology for hyperphosphatemia would be excess exogenous sources of phosphorus. So this could be instances in which there's excess PN phosphorus levels, potentially excess oral intake, and potentially instances in which there has been excess phos containing laxatives on board. So some treatment and management options for hyperphosphatemia are going to be things such as limiting those exogenous sources. So again, that could be PN, oral intake potentially, if there's any kind of supplemental, switching what kind of laxatives the individual might be on, trying to just reduce the outside sources. If you have an individual with a functioning GI tract, you may also consider the usage of phosphorus binders. These are medications that can be utilized to help bind up and reduce the absorption of phosphorus from the GI tract. A typical example of that is calcium carbonate. For an individual who may be on enteral nutrition, you can consider a renal enteral nutrition formula. This could be helpful since they have reduced phosphorus content. And finally, for individuals who are very severe, we may see the usage of renal replacement therapy. So as you can tell looking at both sides of the screen, it's clear that the etiologies can be a little bit complicated for hypo or hyperphosphatemia. So being able to look clearly and see what your patient is experiencing, trying to manage based on the etiology if at all possible, and making a management plan that works for your individual patient is going to be critical here to being able to get back to that phosphorus normal range. So let's pop back over to our other screen and we'll wrap up with some last minute tips.
All right, so your last reminder here on phosphorus management for your clinical patients. If you are managing phosphorus, you need to also have in the back of your head a thought about precipitates in parenteral nutrition bags. If you're providing phosphorus in the parenteral nutrition bag, you need to think about not only the phosphorus but also the calcium components. Phosphorus and calcium in too high of quantities in the parenteral nutrition bag, which is really a bag of chemicals, can lead to a precipitate. This is that solid formation, kind of looks like small crystals, granules, kind of like a little kind of chalky substance, but solids within the parenteral nutrition bag. This can happen in any bag that has too high of calcium and or phosphorus levels. It's kind of a combined level because both of them can cause this problem together in abundance or separately in abundance as well. But for the phosphorus and the calcium precipitates, it's particularly a concern when we can't identify that it's there. If you have a clear bag of solution, you're most likely going to see cloudy chunks of stuff in it that you'll say, wow, that's not right. But a time when it can be a super concern is a time when you can't identify the problem. This is mostly an issue when we're looking at 3-in-1 bags. If we think about 3-in-1 bags, they have all of your macronutrients distributed in them, including lipids. And lipids in a bag typically look a little cloudy, foggy, kind of more of an opaque color. Definitely not a clear solution. So if you have lipids involved and you cannot see all of the crystals, sediment, and formation of any kind of precipitate, that's when we're really going to have some problems and we're really going to be concerned about potentially infusing that bag. So we need to know if there's ever a formation of any kind of precipitate, we don't want to infuse the bag. And the reason we don't want to infuse the bag is because we have a lot of concern for problems. First off, very simply, you can see catheter occlusion. You can see occlusion of the tubes that are trying to send all of this into the system. Okay, so that's not going to be very effective if you're trying to infuse anything. Secondly, you can also see particulate embolization, which means you're going to see some small particle that's coming into the system and potentially can start to block vessels, including blocking blood flow. This can lead to instances not only of some inflammation in the system, but also potentially multi-organ failure, and if it's very severe, death. So we do not want to infuse anything that have any of this precipitate in it, and so certainly we want to avoid any precipitate forming in general. So remember, PN is really just a bag of chemicals, and we do typically utilize some sort of software as well as other experts in pharmacy to help us compound these bags to make sure that they're safe for our patients. Thankfully, everyone knows about having parenteral nutrition with adequate but not too much calcium and phosphorus in them. So most of your kind of compounding softwares that you have in your hospital will probably have some sort of a safeguard system in place that will say, hey, that's too much. Don't add that much. You need to revise to try and make sure that we have appropriate chemistry in the bag in general and that we don't introduce this risk to our patients. But if you're ever thinking about phosphorus, just make sure to keep in mind that precipitates can be a concern and we want to avoid them at all costs. So hopefully this video was helpful for you to learn a few tips and tricks about phosphorus management, both for hypo and hyperphosphatemia. I know that this is a common concern for patients, and hopefully this will give you a little bit more confidence when you're starting to manage phosphorus for your patients. If you have any questions or comments, please feel free to leave them in the boxes below, and we look forward to seeing you next time.